Hello and good morning, everyone. My name's Jeff. I'm the Director here of Insight. It's my great pleasure to welcome you here today for our second seminar for the semester. Before I proceed, I'd like to acknowledge the traditional owners of the land on which we're gathered today and pay respects to elders past, present and emerging, and extend that welcome to anyone in the room or in webinar land who is of Aboriginal and Torres Strait Islander origin. It's a really big week for lots of people in our sector. Yesterday was International Social Workers Day, so respect to all social workers out there like me. Today is International Day of Happiness, so it's good to see all of your happy faces. And tomorrow is Harmony Day, where we respect all cultures and living together harmoniously. So it is a big week for everyone. But on International Happiness Day, I'm very happy to invite Michelle Combo to this presentation to talk about trauma-informed models of care. Welcome, Michelle.
Thank you. So, I would also like to pay my respects to the traditional owners of this area and all the areas where people are joining us from today. I myself am a proud Gamilaraay woman. I don't know how to point to that map, but it's the little northwest New South Wales pale yellow area. That's where me and my family are from and have been for a long time, several generations, and apparently our family name is one of the original 4 skin groups. So that kind of helps to validate, definitely that's where our roots belong. But I've been living and working in Brisbane, specifically Metro South area, for about 18 years now. I don't date myself too much, so stay young. For just beginning, why it's important to have a different talk, because I know that you actually had a trauma-informed care presentation last year by my colleague Michelle White, and that's still on file for anyone that wants to refer to it. But you know, we have a separate set of guidelines and training project that we've got for Indigenous Australians specifically, and just based on the principles that, you know, we are different and we need to acknowledge that. I think we all know that from practice and from, you know, statistics and just what we observe in the community. So, you know, to be able to recognise that and then act on it accordingly means that we need to have our own separate models and our own separate programs. And, you know, NHMRC backed us up with that too. So we use that to, you know, demonstrate the points. And also I like that little picture at the bottom about equality versus equity, because I noticed a few people, it's really interesting actually in health, because you kind of think that when you get around doing different presentations that everyone would know the difference, but apparently they don't. So I have had a few people say, because equity is one of our core values for trauma-informed care, I have had people ask me, what's the difference between equality and equity, and, you know, why do we have to talk about it in that way? And this picture demonstrates that really clearly. You know, giving everyone the exact same resources or programs isn't necessarily going to produce the fairest outcomes. So, good way of showing that. So what is trauma-informed care? The basic premise is that the approach asks what has happened to you. Thank you, I'm very short, sorry. What has happened to you rather than what is wrong with you. And I think, you know, for most of us that have been working in addiction and mental health services for a while, you can see that it's very common for us to look at what's wrong with someone and look at diagnostics and try to put all those different labels on people, which is not necessarily helpful and doesn't acknowledge their lived experience of trauma. So for the trauma-informed care guidelines that we've been putting together with the Way Forward team from Metro South Addiction and Mental Health Services, we propose that there are 3 key factors that you need to try to achieve for an organisation to become trauma-informed. So to do that, we need to realise the impact of the trauma, recognise the signs and symptoms of trauma at all levels, including for consumers, their families, carers, and for our staff. Because I think everyone forgets that, you know, for our Indigenous workforce, they're also coming from the same backgrounds and having the same sort of community experiences. So it is important to acknowledge and act accordingly for that too. And then the final one is to resist re-traumatisation of anyone involved with the service. And again, that's for consumers and for staff. So based on the project that's been going on since 2016, we did have another psychologist who was doing a lot of the groundwork to see what actually is important for this area. So this is based on Metro South Addiction and Mental Health Services, but it's also applicable to pretty much any area because it comes from a bigger list of what core values you could adhere to. So the 7 that we found were most prominent and most agreed with for our services were respect, safety, recognition and acknowledgement of the impact of trauma, excuse me, flexibility, empowerment, inclusiveness, which includes family and community, not just for the clients, and again, equity. So hence the little picture I had at the start to explain what equity is. So for me, I think the key factors from that I wanted to focus on today is that understanding the trauma context and history for Aboriginal and Torres Strait Islander people. It's very important. Acknowledging the lived experience of complex trauma and the subsequent impact on substance use or abuse. Now, I know there's all sorts of terms in addictions, and I'm first to say that, most of my experience is with mental health. So I have tried to target this content for addiction specifically, but just excuse me if I'm using the wrong terms, because mental health is more my thing, and hopefully it still makes sense anyway. And then the final factor is the importance of cultural safety and flexible service provision, obviously within reason. But our team at Way Forward have been experimenting with that for the last few years across Metro South and Metro North. And we've found some really good results and really good outcomes when we make just small changes for our staff and support that, so that they can practice in a more culturally safe and flexible way, which is not normal for our mainstream services. And I will go through an example of that a little bit later. So these are some of the types of trauma that Indigenous Australians would typically face. It doesn't cover all, there are others, but these are the main ones that we are addressing in our trauma-informed care guidelines. So the first one is transgenerational trauma. It's talking about the inherited impacts of traumatic events, and this is looking at, partially to do with collective trauma as a result of the attempted genocide in this country. So this is the uncomfortable one that people probably don't want to talk about. But, we can't deny our history. There's plenty of evidence there to say that it happened, and plenty of outcomes and results these days to see what it did. So transgenerational is important. Intergenerational is the next level, which I will be showing you a video to demonstrate what intergenerational actually looks like and what it means. But it's talking about the between generations impacts and experience of trauma. And I think while we're going through these, you can imagine how that applies to addiction clients and mental health clients as well. Single event is the typical one that we would normally hear about, especially with things like PTSD. For example, Vietnam vets, war-related trauma, it's usually in that zone. Or, car accidents, home invasions, that kind of stuff. And it's usually easier to treat those ones. And then the last one is complex, which is the one I want to focus on for us here today, just because from my experience, and I'm just speaking on my own experience and my own education, is that this is the one that shows up the most for our addictions clients. And it's not actually diagnosable in the sense of being an Access 1 diagnosis in the DSM. So it sort of gets left in that no man's land, and it, doesn't get treated very well by mental health or addiction services, pretty much across the board. Which we're working on, which is, part of the reason why we've got trauma-informed care guidelines coming, and everyone's, it's quite trendy. It's a flavour at the moment for everyone to get into trauma-informed care, because it actually does cover this huge gap. And hopefully, the trend will stick for a bit longer until we get good at it, because I think all of our services need to learn how to do that better. And when you look at the definition, you can probably imagine, for anyone that does or has done clinical work, you can probably imagine clients that fit in that category. And I would probably hazard a guess, again, this is just my opinion, but having been a practicing Indigenous psychologist in mental health for, and date myself again, more than 10 years, over 10 years, we can say, I would guess that the majority of our Indigenous clients that come through any of our services would qualify for complex trauma. It wouldn't be too hard to, stretch to get to that, if you want to call it a diagnosis. In presentations for what complex trauma can look like, and this is a mixture of information that's available quite freely out there in the world, and is also based on, my experience of working with clients in this area for a long time. So it can look like really difficult manipulative behaviour where people can just show up at clinics and or hospitals, usually at emergency departments, looking like they're throwing tantrums, which I know is also quite common for addictions clients as well for other reasons. But I think for our specific population, it can happen in the absence of drug use because it's just a matter of, lacking the skills to appropriately manage your own emotions. And never having actually been taught effective self-soothing skills, and also combined with having poor interpersonal skills. And, I guess all of that is in the context of living in a post-colonial society, which is not necessarily supportive or helpful, and not really making space for Indigenous people to fit comfortably. So other symptoms, I guess, of complex trauma is having negative self-perceptions, issues with trust, feeling isolated and disconnected, feeling worthless, and difficulty expressing emotions in a socially appropriate way. So that's why we find that it often gets confused with borderline and/or antisocial personality disorders. For the girls, it's usually borderline. For the boys, it's usually antisocial. But these days, they're getting a bit equal. Girls are equal rights. And I think the I'm Hip team can tell us too about what that looks like for the justice population. So it's pretty equal these days, but dissociative disorders is the other one that gets confused where, people get a little bit unsure which category to put it in. And, to be fair, symptoms do cross over for all of those. So it's not an easy, straightforward diagnosis. But because of those mixtures with dissociation and personality disorders, it does actually have good results for using DBT techniques. So anyone that's familiar with DBT, dialectical behaviour therapy, that's the primary recommended treatment for borderline personality disorder or emotionally unstable personality disorder, whichever you want to call it. And that includes things like limit setting, really clear limit setting, clear agreements so people know what to expect. Sticking to those agreements is really important for complex trauma and for Indigenous clients because, we as a people, I think it's pretty fair to say, we've been given the raw end of the stick majority of the time since the country's been colonised. So we're kind of had enough of that. So it doesn't really bode well if you make promises you don't keep, which everyone knows for personality disorder clients, but they forget that for Indigenous clients it's the same. We're used to being lied to and used and abused. So if you can try not to do that with your clients, even if you have good intentions, it's just not good to tell them things you can't uphold. Don't promise to be there tomorrow if you can't get there tomorrow, because it's really not going to help your relationship. And psychoeducation around things that they're lacking. So the distress tolerance, the mindfulness skills, social skills training, and emotion management skills, those are all helpful things as well. And, the thing that I guess governments and health services won't be necessarily happy about is that the other primary recommendation for complex trauma is long-term therapy. And our services don't really support long-term engagement anymore. So we're working on that. We'll just see what comes. We're doing trauma-informed care for now, and then we'll see about the other stuff after. Excuse me, I've had a cough lately. These are the results from a survey that our Way Forward team conducted. It was actually at Musgrave Park, NAIDOC, which is a really big event for the Indigenous community. People come from all around the state to come to that, or sometimes even across the border. And we actually handed out surveys, and we managed to get 33 people to take time out of their fun day to complete it for us. And it was just asking a bunch of questions about, accessing treatment with mental health addiction services, and what the barriers were. So the top four responses we got for where people would go to actually access help for mental health or addictions issues, the number one was the Aboriginal Medical Centre. The second one was their doctor, which might be at a different place, or at the AMS, family or friends. So people weren't looking at the specific mental health and addictions clinics at all. And part of the reasons that, the top four reasons we found for why that was because they were saying things like, I don't think I or my culture would be treated respectfully. I don't think people would understand me. I'd feel shame or too shy, or I wouldn't know where to go, which is pretty common, pretty common responses we hear from people. And it also points to one of the other important factors that we talk about in terms of cultural safety, which I know is becoming one of those terms that also gets a bit overused and loses its meaning, but we will talk a little bit more in a second about what that means. So for us, just going off the definition that was offered by the Australian Human Rights Commission back in 2011 with their social justice report, they said that cultural safety means for Aboriginal and Torres Strait Islander peoples, a culturally safe environment is one where we feel safe and secure in our identity, our culture, and our community. So it does come back to, those points about being respected, feeling like your culture is understood, that you're understood, and that you would be welcome. And little things, it can be very difficult sometimes to not be too tokenistic, because, there's superficial stuff that you can do that might seem like a really minor and superficial thing to you, but for Indigenous people coming into a clinic, it can actually make a world of difference. So if you have Indigenous staff, it'd be good if they were visible. If you have any flags, please put them out. If there are any shirts people can wear, that makes people feel comfortable. There's making tracks and closing the gap stuff that's available out there. You can talk to your cultural capability teams about that. And there's stuff that you can just buy, because people often say to us, like, oh, where do you get your shirts from? And, how can I get one? Like this one I'm wearing now, I bought this myself. That's not a work shirt. I found a company and I bought it because I liked it. So people are welcome to do that too. And it just makes people feel more welcome. Makes a big difference. And so that brings me to the social and emotional wellbeing model. Has anyone in the room seen this one before? It's getting around now. It's been out for a few years. So Pat Dudgeon and Graham G, all, that group, they're all Aboriginal psychologists, put this together a few years ago just to demonstrate, the important aspects for Aboriginal and Torres Strait Islander people, all of the aspects of life that impact on our health and wellbeing, which obviously has a big impact on mental health and addictions. And I think for a lot of people too, we still want to try and clarify that social and emotional wellbeing doesn't replace mental health. It's not interchangeable. Mental health is just another aspect of our health and wellbeing, and so is addictions. It's all influenced by social and emotional wellbeing, but it's not interchangeable. You can't just have this instead of mental health. So connection to spirituality and ancestors is important. Connection to physical wellbeing, connection to mental wellbeing, connection to family and kinship, connection to community, to culture, and to land. And then on the outer ring, we've got, the things that impact on all of that being the historical determinants, the transgenerational stuff, political determinants, the environment, society that we're living in now, it's not good, and social determinants, which also is not great. So keeping all that stuff in mind when you're working with any Indigenous clients actually gives you a better picture of their holistic health, model for themselves, that these are all the different aspects of Indigenous clients that we need to be thinking about. And, just as a side note, you can probably tell pretty quickly when you look at that list of, which ones have been affected or interrupted by colonial practices since, mission times. It's pretty clear links there. So I mentioned before the idea about working with cultural safety and flexibility, doing things slightly differently for our clients. This is an example of a clinic that we established under Way Forward. I mean, obviously these little setups aren't possible everywhere, but we are fortunate enough that here in Metro South we've got the Inala Indigenous Health Service, which is now called the Southern Queensland Centre of Excellence, and it sits across the road from the local addiction and mental health services, actually, because they're co-located too. So literally across the road, but in a well-known Indigenous suburb, Inala. But for years and years, that clinic has struggled to engage in a meaningful way with the Indigenous community. And even though we know and everyone's been very aware that addiction issues have been rife, for decades, but people just would not go to the clinic, they just refused. So the GPs in the Indigenous Health Service were trying to manage it as much as they could themselves, but there's only so much they can do when it comes to managing addictions. And so we've had the Advanced Aboriginal Health Worker. I'll give her a shout out. Her name is Pauline Brown. And she has been sitting there for a little while trying to help the Inala Addiction Service with the engagement and bringing people in. They were getting small numbers, but we decided to trial something different, and we put her, like I said, literally across the road to sit inside the Indigenous Health Clinic for 1 day a week. That was 1 day a week about 1.5 years ago, and she's now doing about 2.5 days a week because of the demand. So this is the, reflection of her outcomes of what she's been able to achieve, and it's been pretty successful. We're all pretty happy with it, and that's why her time was allowed to increase from Addictions and Indigenous Health having a partnership. And she's seeing roughly around 50 people a month at that clinic, which majority of them are people who would not be accessing the local addiction service on their own because they just did not feel safe there. So the cultural safety of the Indigenous Health Clinic is one aspect, but it's also the Indigenous health worker who facilitates and manages the whole clinic so that they can actually feel really safe and secure with that as well. And now we've added, with the bottom graph, addiction services have added one of the doctors from addictions to come across and also join that clinic. And that's also been picking up and doing pretty well, considering most of them, like we said, the majority clients that would not go to the addictions clinic, we're seeing them now, at least we're seeing them somewhere, and they're actually getting treatment. And a lot of them are, getting better. So, which is great too, because that's what we want, not just engagement. We actually want people to get better and link in with all the supports that they need. So, I know that's not possible to replicate everywhere, but that is something that's been very successful for us, and we do hope that that continues indefinitely. At this stage it is. So, the uncomfortable stuff that people don't really like to acknowledge is the colonial background. This is, like I said, we're living in a post-colonial society. People talk a lot about let's decolonize everything. Not really possible when we're still living in this structure. Probably not ever going to be possible. So I think we just have to accept that. But what we can do is try to, acknowledge our history and be honest about it, because our government is still yet to actually do that. And share the education about what things were really like, so that people can understand where Indigenous people are coming from. When you hear people talking about our history being, oh, it was so long ago, let's just move on now. Not really. There's people still alive who were actually part of the stolen generation, and people still alive that remember what it was like to be put on missions and to live there. So, it's not that long ago, and it still impacts on all of us in the transgenerational and intergenerational way. I'm pretty sure that top photo is Native Mounted Police, the white officer from the group. I've been doing a bit of work lately with some archaeologists who are looking into the trauma papers to demonstrate the aspects of trauma that the Native Mounted Police experienced when they were put in that position, because they were, essentially coerced a lot of the time, or stolen as children from massacre sites to be brought up to be Native Mounted Police, and then they obviously would have experienced heaps of different levels of trauma because of that, and so did the communities that they were killing, because either way it wasn't good, but everyone was just trying to survive. So we're doing a lot of work with the archaeologists at the moment, because they want to try, like, part of their goal is to get it all clarified, and they've got a lot of evidence already, but just to put it all in a clear and concise way to actually present to the education department and try and get this put into, mainstream education for secondary schools, because that's what we need is, more honesty about our history so that we can start healing. Because, for anything bad that's happened to people, we all know that people want to be validated. It's like we've got all those movements about Me Too and all that kind of stuff. Like, people want acknowledgement. They want to know that they're believed first and, acknowledge the impact. Then you can heal, then you can move forward. And just a little bit further of that about, again, that looks like Native Mounted Police to me, that Aboriginal and Torres Strait Islander people have been subject to intergenerational and contemporary impacts of patriarchal colonialism, which is what was on the last slide, and discrimination, and therefore experience the criminal justice system in a uniquely destructive manner. And I think it would be pretty safe to extend that to the education system and the health system as well, because they're the three biggest, structures that we're all living under. So this video demonstrates intergenerational trauma, and we'll just get that up and running for you.
The story of our communities, people and nation starts a long, long time ago. more than 60,000 years in fact. This was when our culture and our law first started to thrive. We knew who we were and where we belonged. We took care of each other, our land and our waters. We ate food that made us healthy, lived on country and abided by our laws and song lines. Our families, our children were happy, with strong minds and hearts, because they were where they belonged. But then, everything changed.
Colonisation came, bringing wars, disease, famine, violence, and the destruction and violation of our cultural laws, sacred sites, families, and communities.
We were denied our knowledge, language, ceremonies, and identity, the very things that tell us who we are and where we belong. And our connections with each other and the land grew weak.
And then, our children were taken from us. They had their names changed and their identities stripped away. They were told that Aboriginal people were bad. Worse still, they were told that their parents and grandparents did not want them.
For years this happened, and those children became known as the stolen generations.
Our children were denied love and experienced physical, emotional, and sexual abuse. This left very deep, very complex, and very real wounds, leaving scars that are still being felt personally, socially, spiritually, and collectively.
In the time when our story started, we were able to parent in the cultural way that has seen our families survive and thrive for generations. Our people were strong, and our culture flowed and healed us in times of hurt.
But since the trauma of colonisation and the stolen generations, we have not been able to heal in the same way. And we have unknowingly passed this trauma on to our children through sharing our sad stories and having them witness and experience our pain. This is known as intergenerational trauma, and we see symptoms today in broken relationships, disconnected families, violence, suicide, and drug and alcohol abuse.
But this is not where our story ends. We still have strong minds and hearts, and we still know who we were and where we belong. By creating safe and strong communities together, supporting our families to be free from pain, returning to our culture and building a strength of identity, we can stop the cycle of trauma and bring about positive intergenerational change, so that we can continue to thrive for the next 60,000 years. There are simple things that we can all do to help heal our trauma.
Visit healingfoundation.org.au to find out more.
So a couple of other things. I'm conscious of trying to leave time for questions at the end, but I'm also just wanted to mention the impact of racism. So I don't know if everyone here would be aware, but at least for Metro South, we've got a few investors in Gold Coast are doing the same project, where we are rolling out a workshop called Courageous Conversations About Race. And that whole thing is to talk about, again, it's acknowledgement of the history, the systems, institutional racism, and how that affects people's health now. And when you think back to the social and emotional wellbeing model, it makes a lot of sense, why such things would have an impact on someone's physical health right now. And then that goes on to addiction and mental health issues as well. So Dr. Tracy Westerman is an Aboriginal psychologist from Western Australia who's been doing a bit of work in that area. And she recently stated that, the research has shown that racism impacts on Aboriginal people in the same way as a traumatic event. So that's just, putting a bit of evidence behind what we already know, but being able to highlight it as an important thing for us to be working on. So hence we've got the Courageous Conversations About Race workshops, and I'm not sure if they will end up being available statewide eventually, but for now it's just a Metro South and project, and Gold Coast are going to be starting up pretty soon too. So Also, the National Strategic Framework for Aboriginal and Torres Strait Islander people's mental health and social and emotional wellbeing, the current version, highlights the impact of racism within the health system and the importance of us addressing these 5 strategies, such as education on the impacts of racism for Aboriginal and Torres Strait Islander people, challenging false beliefs and stereotypes and providing accurate information, implementing Indigenous leadership in program design and development. So that's 3 of the suggestions that they had, which we're doing in bits and pieces, but they're usually not permanent, and that also causes issues. So keep working on that. Another quote from Tracy from recently was in relation to the coronial inquest in Western Australia after they had several, young people commit suicide, and, it got to a point where I think it ended up being around 13 or so by the end that they decided to do an inquest. And this is in, short time frames. So one of the things that everyone in the Indigenous academic and health space is quite upset about right now is that a lot of the recommendations were pointing towards FASD being a huge issue, even though there weren't any diagnoses of FASD actually found in the children, which means that people are still coming out with these recommendations of, okay, let's just restrict alcohol access and let's, put more police in those communities because I'm sure that's going to help. Some sort of adopt a cop program. I don't even know what that's supposed to do, but these are all the recommendations that seem very superficial to me, and it seems very much like they're, putting the blame and the responsibility back on the community and the community members, rather than looking at the deeper, causes of where this all came from. And it's pretty frustrating that stuff is still happening. And one of the final points I just wanted to make was about valuing Indigenous knowledge, that, we all do have a responsibility for being aware of our relationships and our interactions with any Indigenous clients that we work with, but also just to be conscious that you do have Indigenous addiction and mental health workers available for consultation and advice. And, even if they're not able to be the primary clinician for any of those, because, it's set up differently all around the state, but if they can't take on the full load of looking after that client, they can still be heavily involved with advice and assistance. And I think it's really important for us to give that knowledge its rightful place and be able to, value it appropriately, because at the moment it's erratic. It's a nice word. And local Indigenous knowledge is most important. So, that's something that we have to keep remembering and reminding people that, so we're here in Metro South. Way Forward is your team that you can talk to. And then there's, other teams like I'm HIP and other positions that are available. But for the rest of the state, if you don't have anyone or any team specific that you can access, we do actually have a statewide Indigenous mental health, alcohol and other drugs leadership group that you can contact, and you can get to that group either through the Way Forward account, because our admin manages the admin for that group, or there is an IMH AOD email address that you can find on Outlook. So, we'd be more than happy to assist people with any sort of queries, and we would just rather that people sought Indigenous advice for any of your clients that you're seeing that are from our population, because, sensibly, we would hopefully be able to help you with that, and we would probably know a bit more about it. And one of your resources that I looked at was the National Drug Strategy, the current one, which I don't know if that's going to run out soon because it goes to 2019. But the National Aboriginal and Torres Strait Islander People's Drug Strategy also has some pretty good recommendations that are in line with the trauma-informed care stuff that we've been talking about, and that mental health are working on too. So if you're curious at all, that's one of the ones that I didn't mind. It was all right. And I think that's about it. So questions? We have time for questions or disagreements? Thank you.
Do we have any questions from the room? While you think of your questions, we do have a couple online. There was a query about Dr. Noel Heyman.
Yes.
And does he work with you?
Yes.
Yeah.
Yes. I know Noel. I saw Noel yesterday. Noel is the director of the Indigenous Health Clinic, the Southern Queensland Centre of Excellence, and an Aboriginal GP, and the boss of my substantive position. So, yes.
Hi, Noel. And people are querying about the Courageous Conversations, whether that training is available outside of, say, Southeast Queensland.
Maybe, and I think there's a couple of pockets within universities that I've heard about. One in WA and one down in Lismore. but I don't know if they're actually open to training other people. As far as I know, our group is the first to bring it into health, because the program was actually designed for education, and it's very widespread and popular in America for that, because that's where it came from. And then there's a New Zealand group who actually have the license for the Asia Pacific region, and they've brought it to us. So we're essentially under their guidance still at the moment. And yeah, there's, like I said, Gold Coast is coming along next, and that's the only two groups that I'm aware of.
I have a question from online as well. Can anyone wear an Aboriginal and Torres Strait Islander shirt? So as a non-Indigenous staff member, is it okay for...
That's a question that we've had a few times actually as our team. And I think, anything that you do when it comes to other people's cultures, if you do it genuinely and if you actually acknowledge where it comes from, then it's fine. It's the whole idea of cultural appropriation actually comes from people just stealing stuff and not acknowledging the source. And that's why they get in trouble, because they claim it as their own. And with most minority groups and other cultures have had enough of that. So we'd like to have some sort of recognition. But we do actually find people respond well when you genuinely wear a shirt that has any of our artwork on it. Yeah.
It was interesting in your survey that people felt like they couldn't come to our service because they wouldn't be understood or anything. We've dealt with on ground floor with a number of Indigenous people, and they've always had pretty positive effects and outcomes. Do you think there's a need for education that really we're not that bad?
Yeah, on both sides, and we do actually try to work with that too. And I guess having the Indigenous staff available makes it a bit easier to build a bridge and to, open the doors to get people to at least come in and see for themselves that, clinics aren't as scary as what you think they're going to be, and they're not as punitive either, because that's usually the concern for people. And I guess that's the other reason why a lot of our clients that show up, especially in places like emergency departments, and they're, usually considered playing up by that point, it's because we leave it as a last resort. Most of our community members will refuse to go to hospital or any addiction and mental health clinics because they're scared of getting locked up. That the general belief out there is that if I go there, they're going to lock me up, they're going to put needles of whatever drugs into me, I'll have no control and no say, and I don't know what's going to happen to me. And that's just too scary for anyone to even think about. So if they show up at ED, it's usually out of desperation. Yeah, and I guess for clinics, we're still working on the community-based, area to area, teaching people that it's not so scary. Yeah.
That's why I was concerned with the bar charts for Inala, which is reflected to loads of drug services. The access to services for women, because, of course, Indigenous women, like any women accessing a drug service, believe their children will be taken, and they usually are.
Well, not with us.
No, I work in that, and I see the insufficient, or that's not even a good word, when there's supposedly a cultural plan. This is not a go at child safety specifically, but I see drug workers too, and family workers not really entering into what would be useful to those families and those women.
Yeah, and I guess that's why when we get people coming to our clinics, like the Centre of Excellence at Inala, most of our staff there, and especially for all of the Indigenous staff, normally that's where I would work when I'm not working for this project. And so being an Aboriginal psychologist and having an Aboriginal social worker plus an Indigenous director, we've got Aboriginal and Torres Strait Islander health workers and client support officers, research officers, and all of anywhere in between. So all of that makes the clinic and the whole service much safer for people to feel like they can actually speak honestly about their concerns. And it's not uncommon for us to get people saying, I'm going to tell you something, but I'm really worried that if anyone else finds out, especially child safety, that it could lead to my kids being taken away. And of course, we're very conscious of that, and we're very mindful of how we manage that. Yeah.
I realise you are, but there's still, about 50% less women in those bar charts accessing.
Yeah. But I think a lot of the women that are coming through too, they're already linked in. So even though we've got Pauline sitting inside the Centre of Excellence for her addiction-specific clinics, she's sitting near the allied health, and we've also got visiting psychiatry, which both of them are Indigenous regs. And we've got all of that linked into. So a lot of the women would actually be getting diverted off into the child health clinics and the allied health clinics instead of going to Pauline's addictions clinic alone. So that's where most of them are picking up their services instead, if that makes sense. Like, we're still seeing a lot of women with addiction issues. They're just not necessarily going to that clinic. Yeah.
I'll ask a quick question. Any practical tips, particularly maybe for non-Indigenous workers, about some of those courageous conversations or asking about impact of racism, intergenerational trauma, complex trauma with Aboriginal clients or Torres Strait Islander clients we might come in contact with?
Yeah, okay. So I think two of the main things that it comes down to for me is education. Because sometimes even our own community members don't fully understand the impacts of history on how they currently feel. And I have had even young people who've, come for psychology referrals, and they've been really, really, complicated and really messed up with all sorts of things going on. And when I educate them about things like, do you know about transgenerational trauma, and let's talk about that, it just doesn't fix everything, but it puts it in a different perspective where they can go, oh, I knew there was a name for it. Like, there's actually a thing. It's not just me or my family being a bit crazy. Like, this is actually a thing that's happening to a lot of people. And it just makes people feel a bit validated in the sense of going, okay, so it's not my fault. It's actually something that's a result of the environment and the history. So teaching them about that can be a really big step forward. And just, upfront, honest and, again, genuine conversations about how they want to be treated, how they want to be addressed, and, how you want to work through things together in a way that's safe for them. Yeah. And if they do have any other supports or, Indigenous staff who they want to bring into that relationship, so that it makes them feel a bit better about opening up, because sometimes you need to do that too.
You've answered all the questions, Michelle. A round of applause again for Michelle and that excellent presentation. Thank you very much.